You know that feeling, right? You see your dog maybe favoring a leg,
Yeah.
not quite putting weight on it, or your cat's just off, not jumping like usual.
Yeah, and your first instinct is offered to jump online.
Exactly. But sometimes, those quick searches, they just don't cut it. They scratch the surface. That's why I want to go a bit deeper today.
We really do. We're going to be digging into canine and feline bone hemangiosarcoma, HSA for short.
Okay, HSA. That sounds, well, it sounds pretty serious. And it is. We're talking about an aggressive cancer here.
It is serious.
But the idea today isn't to, scare everyone. It's more about giving you a real solid understanding if, heaven forbid, this ever becomes relevant for your own pet.
Precisely. Empowerment through understanding. So hemangiosarcoma, fundamentally, it's a cancer that starts in the cells lining blood vessels, the endothelium.
Okay, lining of the blood vessels. And they're everywhere, obviously.
They are, which is why HSA can appear in different spots. But today, we're focusing specifically on bone hemangiosarcoma, where the tumor actually originates in the bone itself.
Right. And here's something important right off the bat from what I've seen in our sources. Primary bone HSA, the kind that starts there, it's actually pretty uncommon in dogs.
That's a key point. Less than 5% of all bone tumors in dogs are this type.
Less than 5%. Okay. And in cats.
Extremely rare is the term used. Really, really uncommon in cats.
So statistically, if your pet has a bone issue, it's probably not this specific thing. Well, that's somewhat reassuring, I guess.
It is important perspective. So yeah, our deep dive will mostly be about dogs, though we'll mention cats where relevant. The mission is really to pull out the key info, the basics, diagnosis, treatment, so you can get a handle on it.
Okay, let's unpack it then. So, aggressive cancer, blood vessel lining, starts in the bone, but it's rare. You also mentioned something about it being tricky to tell if it started in the bone.
Ah, yes, that's a crucial diagnostic challenge. On regular x-rays, the way primary bone HSA eats away at the bone can look, well, almost identical to a tumor that spread to the bone from somewhere else.
Like from the spleen, maybe. Isn't HSA more common there?
Exactly. Spleen, liver, heart. HSA is more frequent in those organs, so if you see a lesion in the bone, you can't immediately assume it started there. It could be metastasis.
I see. So the x-ray is just the first clue, not the whole answer. Needs more digging.
Definitely needs more digging.
Okay. So in dogs, assuming it is primary bone HSA, where does it tend to show up? Which bones?
The sources point to two main areas, appendicular sites, so that means the limbs, the legs.
Legs. Okay. Makes sense. Maybe easier to notice lameness there.
Right. And then actually meaning the central skeleton, the most common spot seems to be the ribs.
The ribs. Huh. Okay. And just to hammer it home, cats?
Still extremely rare. Really a footnote in this specific context.
Got it. Primarily dogs, legs, and ribs. Now, you mentioned some breeds earlier. Are there specific dogs that are more likely to get this?
Yes. The data suggests a predisposition in certain breeds. Golden retrievers, Labrador retrievers, and German shepherds seem to pop up more frequently in the case reports.
Those are incredibly popular breeds.
They are. So important to be aware if you have one. But again, remember the overall rarity. It's not common even in those breeds.
Right. Context is key. What about age? Is it a puppy thing or older dogs?
Typically middle-aged to older dogs. That's the usual window. And for those super rare cat cases, it also tends to be older cats.
Okay. Older pets. Anything about male versus female?
There's a possible slight lean towards male dogs, but it doesn't seem like a really strong link based on the sources.
Interesting. So maybe an older, large breed dog, possibly male, slightly higher index of suspicion, but still low overall odds. Okay, let's talk signs. What would you actually see? What should someone look out for?
If it's in a limb, the signs are often what you'd expect with a bone issue. Pain is a big one, so lameness, maybe reluctance to put weight on the leg.
Just general limping.
Yes. You might also notice some swelling in that area, maybe even feel a distinct lump or mass.
Okay.
And then there's the really concerning possibility of a pathologic fracture.
Pathologic.
Yep.
Meaning the bone breaks just because the tumor weakened it.
Exactly. Not necessarily from a major fall or injury, but just normal activity might be enough to cause a break because the bone structure is compromised.
Wow, that's scary. Okay, and what if it's not in a limb? Like those axial sites, the spine, or ribs?
Signs can be quite different then. If a vertebra in the spine is affected, it might collapse and press on the spinal cord.
Oh, right.
That can cause what's called myelopathy, basically, spinal cord dysfunction. So you might see weakness in the hind limbs, wobbliness, difficulty walking, maybe even paralysis, depending on the severity.
So neurological signs.
Correct.
Yeah.
If it's a rib, you might see or feel a swelling on the chest wall itself. And if the tumor grows inwards into the chest cavity,
That sounds bad.
It can be. It can lead to bleeding into the chest, which is called hemorrhagic pleural effusion. That can cause difficulty breathing, rapid breathing, lethargy, serious respiratory signs.
Okay, so the signs really depend heavily on where the tumor is located. Legs versus spine versus ribs.
Yeah.
Very different presentation.
Absolutely. Location dictates the clinical picture quite a bit.
Now, the big question, the why. Do we know what causes bone HSA? Any known risk factors? Things people can avoid?
This is unfortunately one of those frustrating areas in oncology. The sources are quite direct here. The causes and specific risk factors for primary bone hemangiosarcoma are currently unknown.
Still a mystery. That's tough for prevention, obviously.
It really is. We just don't have that piece of the puzzle yet.
Okay, so if the why is unknown, let's move to the how. How do vets figure this out if they suspect it? It sounds like it can mimic other things.
It definitely can. That's the starting point for diagnosis, considering the differentials. What else could this be?
Like other bone cancers.
Right. Osteosarcoma is the most common bone cancer in dogs, so that's a major differential. But also things like fibrosarcoma, chondrosarcoma, even metastatic cancer that spread to the bone, as we mentioned.
And infections. Could an infection look like this on an X-ray?
Yes, a bad bone infection, osteomyelitis, can sometimes cause bone destruction that might look similar on imaging initially. So ruling that out is important too.
So lots of possibilities. You mentioned osteosarcoma.
Yeah.
Is there a specific type that's particularly hard to distinguish?
There is. It's called vascular telangiectatic osteosarcoma. It's a subtype of osteosarcoma that's very rich in blood vessels, and under the microscope, it can look remarkably similar to hemangiosarcoma.
Ah, so even looking at the cells isn't always straightforward.
Not always. It often requires specialized staining techniques, what we call immunohistochemistry, to really nail down the origin of the cells.
We'll come back to that.
Yep.
What about basic blood work, like a CVC, chemistry panel, urinalysis? Do those help?
They're always part of the workup, but for primary bone HSA, they're often less revealing than for, say, splenic HSA, where you might see more dramatic changes related to bleeding.
Oh, yeah.
You might see some things, though. Regenerative anemia, perhaps, if there's been some chronic low-level bleeding, maybe low platelets, thrombocytopenia, or a high white blood cell count, leukocytosis. But it's not consistent. Normal blood work doesn't rule it out.
So helpful context, but not diagnostic on its own. Imaging seems key then. We talk about X-rays showing bone destruction. What else?
Well, standard X-rays show that typical appearance, often a kind of moth-eaten, poorly defined lytic lesion, meaning bone-destroying, often without much new bone formation around it, and they'll show a pathologic fracture if one's present.
Okay.
But critically, you absolutely need chest X-rays, 3 views usually.
To check for spread to the lungs.
Exactly. Lungs are a very common site for HSA metastasis, so staging, checking for spread is vital right from the start.
Makes sense. What about ultrasound?
Abdominal ultrasound is important to check organs like the spleen and liver, again looking for either a primary tumor there that might have spread to the bone or for metastasis from the bone tumor. Sometimes cardiac ultrasound too to check the heart.
So scanning the main body cavities, our sources also mention CT scans. What's the advantage there?
CT offers much better detail, especially of the bone itself. It can really help define the exact extent of the tumor, how far it reaches. This is super important for surgical planning.
Especially for those tricky axial spots, like the spine or ribs.
Precisely. Knowing the exact margins is critical there. Plus, CT is generally more sensitive than chest X-rays for detecting small metastatic nodules in the lungs.
So CT gives a clearer picture overall, both locally and for potential spread. Okay, imaging gives strong clues, but you still need to look at the tissue itself for a definitive diagnosis, right? A biopsy.
Absolutely. The gold standard is an excisional biopsy, removing the entire tumor surgically and sending it for analysis. That gives the pathologist the whole picture.
But that's basically the surgery itself. What if you need a diagnosis before a major surgery like amputation?
Right. In that case, an incisional biopsy might be done, where just a small piece is taken. But there's a catch with HSA.
Because it's so vascular, bleeds a lot.
Exactly. These tumors are full of leaky blood vessels. Getting a biopsy sample can sometimes lead to significant bleeding, and the sample itself might be mostly blood or clot, making it hard for the pathologist to interpret. It can be challenging to get a good representative piece.
And that confusion with the telangiectatic osteosarcoma comes up again here too, I imagine.
It does. A small, potentially blood-filled sample can make differentiating those two very difficult sometimes without those special stains.
Okay, so biopsy is needed but maybe not always straightforward. Assuming you get a good sample, what does the pathologist actually see? Grossly, like just looking at it.
Grossly, it often looks like a dark reddish, sort of crumbly, fragile mass, often found within the marrow cavity, the inside part of the bone,
Dark and crumbly.
and under the microscope.
Microscopically, you see these abnormal sort of spindle-shaped cells, they call them anaplastic mesenchymal cells, arranged in disorganized cords or sheets. There's usually a background matrix, and critically, you see these poorly formed vascular channels or spaces filled with red blood cells, maybe some thrombi, clots, and often areas of necrosis or dead tissue.
Sounds like a mess, cellularly speaking.
It often is quite chaotic looking.
And those special tests, the immunohistochemistry you mentioned, how does that help confirm it's HSA? Right, so that's where they use specific antibodies that act like tags. They test for proteins that are characteristic of endothelial cells, the cells lining blood vessels. The key markers are usually von Willebrand factor, sometimes called factor VIII-related antigen, or another marker called CD31 or PCAM.
So if the tumor cells light up with those tags, it confirms they came from blood vessel lining.
Essentially, yes. It confirms the endothelial origin, which is the defining feature of hemangiosarcoma, and helps distinguish it from other tumors, like that tricky osteosarcoma subtype.
Got it. So a multi-step process. Suspicion based on signs and breed, imaging to locate and stage, then biopsy with potentially special stains for the final confirmation.
That's a good summary of the diagnostic paths.
Okay. Diagnosis confirmed. Bone HSA. What's next? What does treatment look like? You said aggressive earlier.
Yes, treatment needs to be aggressive because of that high metastatic potential, the tendency to spread. The cornerstone is surgery to remove the primary tumor in the bone.
And as we discussed, that often means
For limb tumors, yes, amputation is very often the recommendation to get wide, clean margins and remove the entire affected bone segment.
and for the axial tumors, spine or ribs.
Yeah.
More complicated.
Much more challenging surgically. Complete removal might not always be possible depending on the exact location and structures involved. Sometimes they might do a debulking surgery, removing as much as possible.
And if you can't get it all out surgically?
That's where radiation therapy might come in. It could be used after an incomplete surgery on an axial tumor to try and kill remaining cells, or sometimes purely for palliation, just to help control pain if surgery isn't an option.
Okay, surgery is step one for the local tumor, but you keep mentioning the spread.
Right, and that's why surgery alone is rarely enough for HSA. Adjuvant chemotherapy, meaning chemo after surgery, is strongly recommended.
Even if the chest x-rays and ultrasound were clear.
Yes, because we assume there are likely microscopic cancer cells, micrometastases, that have already spread but are too small to see on imaging. Chemo aims to target those.
Makes sense. So what chemo drugs are typically used?
The main workhorse drug for HSA, according to our sources, is doxorubicin. It's an intravenous drug.
Doxorubicin. Okay. And how is it given?
The sources give specific dosages based on body surface area, slightly different scales for smaller versus larger dogs, and a dose for cats too, though again, super rare. It's typically given every 2 to 3 weeks for about 5 treatments, 5 cycles.
5 cycles every few weeks. That's a commitment. Any other chemo approaches mentioned?
Yes, there's also mention of using metronomic chemotherapy.
Metronomic. What does that mean?
It means giving a low dose of a chemo drug, usually orally, on a daily or near daily basis long term. The drug often used is cyclophosphamide.
Low dose daily instead of high dose every few weeks.
Right. The idea isn't necessarily to directly kill lots of cancer cells with a big hit, but more to create an environment that's hostile to tumor growth, potentially by interfering with the tumor's blood supply, anti-angiogenesis, and maybe modulating the immune system.
Interesting approach. Is it used alongside the doxorubicin?
It can be. Sometimes it's combined with an NSAID, a non-steroidal anti-inflammatory drug like piroxicam. This combo might be started during or after the doxorubicin cycles and continued as a maintenance therapy.
Okay, so doxorubicin for the main hits, maybe metronomic chemo plus an NSAID for longer-term control. What if the doxorubicin doesn't seem to be working or the cancer comes back? Any rescue options?
The sources mention vincristine and higher doses of cyclophosphamide as potential drugs that might be tried in that situation as rescue therapy.
Good to know there are other options, though hopefully not needed. No, these are powerful drugs. We had to talk side effects, right? Contraindications.
Absolutely crucial. Doxorubicin, while effective, has a list of potential side effects owners need to be prepared for.
Like what?
Gastrointestinal upset, vomiting, diarrhea, loss of appetite is pretty common. bone marrow suppression leading to low white blood cell counts, which increases infection risk, or low platelets.
Okay, GI and blood counts. Anything else?
Yes, potential heart toxicity, especially in dogs. It can be cumulative, meaning the risk increases with the total dose received over time. Kidney toxicity can occur, though less common. Allergic reactions are possible. And it's a drug that can cause severe tissue damage if it leaks out of the vein during infusion.
Wow, that's quite a list. Requires careful administration and monitoring. What about the cyclophosphamide used metronomically?
The main concern mentioned, particularly in dogs, is sterile hemorrhagic cystitis.
Bladder inflammation with bleeding, but not from infection.
Correct. It's an irritation caused by metabolites of the drug excreted in the urine. It can be quite painful.
Okay. And the NSAID, piroxicam.
Standard NSAID discs apply potential for GI ulcers or irritation and possible effects on liver and kidney function, especially with long-term use.
So managing potential side effects is a big part of the treatment plan, which leads to follow-up. How often do pets need to be checked after finishing chemo?
The recommended schedule is pretty intensive initially. Physical exams, blood work, chest x-rays, and abdominal ultrasound, typically every 3 months for potentially the first year or two.
Every 3 months. Looking for any signs of recurrence or spread?
Exactly. Trying to catch anything early if it does come back. And for those dogs on long-term metronomic cyclophosphamide, they usually recommend monthly urinalysis to screen for that sterile hemorrhagic cystitis.
Okay, ongoing vigilance is key. Let's circle back quickly to prevention. Since we don't know the cause, still nothing we can do.
Unfortunately, no. The sources reiterate that point. Currently, no known preventative measures or ways to avoid bone HSA.
Right. And what about complications from the disease itself, not the treatment? We mentioned pathologic fractures.
Yes, fractures are a major risk with bone weakening. Also, the potential for tumor rupture and bleeding is significant.
Especially those rib tumors bleeding into the chest.
Yes, or even metastatic tumors in organs like the liver or spleen rupturing that can lead to acute collapse, fluid in the abdomen, hemoabdomen, or severe anemia.
So, some potentially sudden and critical complications can arise from the tumor itself. Okay, putting it all together. What's the bottom line? The expected course, the prognosis.
Well, it's consistently described as an aggressive cancer with a high metastatic rate. Because primary bone HSA is rarer than, say, splenic HSA, the survival stats specifically for the bone form aren't perfectly defined in large studies.
But the general outlook isn't great.
Unfortunately, no. With surgery alone, the prognosis is considered poor. Our sources suggest less than 10% of dogs survive a year.
Less than 10% with just surgery. Wow. Does chemo improve that significantly?
Chemotherapy is definitely given with the aim of improving survival times by controlling that microscopic spread. However, the exact improvement isn't well quantified specifically for bone HSA in the sources we reviewed. The prognosis, even with chemo, is generally considered guarded to poor, potentially similar to the outlook for splenic HSA treated with surgery and chemo.
Which is also quite guarded, often measured in months rather than years for many dogs.
That's often the case, yes. It remains a very challenging cancer. So, a tough diagnosis. Aggressive. High risk of spread. Guarded prognosis even with the best current treatments. Really highlights the need for quick action if signs appear.
Absolutely. Early diagnosis, accurate staging, and prompt aggressive treatment involving both surgery and chemotherapy offer the best chance, even if the overall odds remain challenging. Awareness of signs, especially in those predisposed breeds, is key.
This has been incredibly informative, though sobering. We've covered the basics, who gets it, the signs, the complex diagnosis, and the aggressive treatment approach for bone HSA. It's a lot, but hopefully gives people a much clearer picture.
It's a complex condition, and having this foundation helps understand the discussions you might have with your veterinarian if faced with this. And it certainly underscores why research into better treatments and understanding the causes is so vital.
Absolutely. And maybe that's a final thought for our listeners. Given that the causes are still unknown, what avenues of research do you think might hold the most promise for actually getting ahead of this disease in our dogs and cats? Something to ponder.